HIV/AIDS testing is deemed a pivotal in the fight against HIV and AIDS as it capacitates the individual to protect their health, life and future. The growth of new infections continues to pose serious health risks, and with health authorities placing HIV infections at close to 250,000 or 10% of the Namibian population, this is definitely a topical issue in commemoration of World AIDS Day. Now, worryingly, a significant number of Namibians remain unaware of their HIV status. Good evening and welcome to Talk with the Nation. I'm Patrick Sam, and Nanda Shapao is our sign language interpreter for tonight. Now, according to the latest UNAIDS report, new HIV infections are rising in around 50 countries in the globe, and with AIDS remaining the #1 killer in countries such as Namibia, this year's World AIDS Day commemoration was held under the theme, Know Your Status. Is this an indicator that prevents methods such as early testing? Aren't we working? And how do we encourage voluntary testing? Are some of the questions and pivotal ones that need to be answered here tonight. Now, to help us unpack, I think, a very continuous issue that continues to impact our communities, we're joined here to, obviously, my left, starting with Mr. Albert Tjiroze, who is the Acting Chief Health Program Officer in the Ministry of Health and Social Services. Good evening, sir. Welcome to Talk with the Nation.
Good evening. Thanks for having me.
Next to him, we have Mr. Emmanuel Shiafeni, who is an AIDS activist. Good evening, sir. Welcome to Talk with the Nation.
Thank you so much.
And next to him, we have Mr. Tjiroze, who is the Deputy Coordinator at PEPFAR.
Good evening.
Thank you for coming. And Mr. Sandy Tjiroze, who is the Executive Director of NANASO, the Namibian Network of AIDS Service Organizations. Now, before we get into tonight's discussions, let's take a look at an incident, that was produced by TV Current Affairs producer Ndishishi Hamufungu.
HIV testing is a key component of HIV prevention. It is this critical clinical encounter that serves as the starting point for diagnosing and treating persons who are infected and delivering preventative services to those who are uninfected.
It's really the first step to make that decision to protect your life, to protect your health, and to protect the health of your loved ones. It starts with that very simple but yet very important step, to know where you stand in terms of HIV infection.
HIV testing has improved dramatically since the first generation of tests came out in the 1980s. Then, patients exposed to the virus had to wait months for markers to reach detectable levels. A positive screening result often meant a return visit for further testing. Today, more and advanced methods like rapid testing have better equipped stakeholders.
So that's where you lose people for not accessing services immediately. But today, medical technology is so fast and is so compelling that we are able to provide this testing within the same day, within a few minutes, and also access HIV treatment, what we call antiretroviral therapy, immediately, the same day. You don't have to wait, because long gone is the policy of waiting until you have a certain level of CD4 cell count. Today, you can access these services, and I would really want to applaud our government for making all these efforts to make sure that we protect the life of our people and everyone who feel the responsibility of protecting themselves and accessing these services for free.
But there also needs to be a shift in how these tests are conducted. Field-based organizations like Total Control of the Epidemic, TCE, have found new and targeted approaches to HIV testing.
They initiate what we call index partner testing. They help the client on how he or she is going to disclose the status to the sex partner, and then how they are going to encourage their sex partners to participate on HIV counseling and testing. So once the one who is the field officer who is at the facility get the list of people who are tested positive in the health facility, and then that field officer, then she will share the list with the list in the community, and then those in the community, they carry out the HIV counseling and testing. And then so what we have find out is that, of course, with this system, we are not testing more people as usual, but we are finding more HIV cases. So the positivity rate is high.
But despite this progress in HIV testing, Health and Social Services Minister Bernard Haufiku at the recent 30th World AIDS Day commemoration stated that stigma remains one of the biggest challenges in overcoming HIV and AIDS.
To eliminate
the HIV epidemic on the face of the planet. We must do away with stigma, and we must do away with discriminating. All of us, that is my message. If we do that, then we can forget about achieving our objective, because people will be scared away. They will not come to our services, and they will not take the medication that we're giving them. So stigma and discrimination is our enemy in our effort to control the epidemic.
Namibia used to have one of the highest HIV prevalence rates in the world, but in the past 15 years, the number of new HIV infections has halved. But the high infection rate among young people aged 15 to 24 years continues to worry health officials. But through continued awareness like HIV testing, officials are confident that this number can be brought down. HIV testing remains the cornerstone of HIV prevention efforts.
Encourage health providers to provide HIV testing to anyone interacting with a health facility to say, oh, by the way, do you know your HIV status? When last did you test for HIV? And also to encourage what they call multi-disease testing. If you're coming in for a headache or for a broken leg, still that services, HIV testing should be central to the whole health-seeking behaviors among our communities. That's the only way we can find those who are living with HIV, to know that they are living with HIV and to access the right interventions.
Interesting perspectives there on HIV and testing. Let's get into the discussion. Maybe, Mustafa, let's start with you in terms of just, Albert, what have been the efforts when it comes to government coming up with programs that want to promote the idea of know your status? Why is this theme important, particularly this year?
Well, the theme is really important, and as looking within the targeted age group, the adolescent girls and young women. This is for mere fact that HIV incidents within this specific group are increasing. And also we have realized that there's poor health-seeking behaviors among this specific group. So that means they're not really going out in terms of testing for them to be able to find out their HIV status. And also in terms of general knowledge, that is also lacking. Again, within this specific group, there's that heightened vulnerability due to social circumstances. That includes the poverty, that includes the economy, and also in terms of educational level. So part of the services that the ministry has engaged in making sure that we try to attract this group. We basically have started providing the PITC, which is basically one of those components where, as provider initiated, when everyone is accessing health services at any specific health institution, they are basically offered for the testing in terms of services. They can basically in terms of decline, because basically, again, it's a voluntary process. And also, there are other processes that are being provided beyond the facility, and this is basically in terms of your index partner testing. So whenever someone has tested positive for HIV, then the services basically go beyond that individual in trying to make sure that we get hold of the partner, and also at times in terms of their surrounding household and making sure maybe in terms of their children or the community at large that might be exposed to HIV are basically, in terms of accounted for and they are tested. So again, there's also in terms of smart generation, which is again targeting the adolescent girls and young women. And this is also in terms of boys at large. So,
I think as somebody who has obviously dealt with, from a practical experience yourself, what is the relationship between the stigma that exists against HIV and AIDS and the will to want to get tested?
The stigma plays a very big role. Currently, there are a lot of people who want to get tested out there, but the experience, what they go through on a daily basis, in terms of, look, you find a group of people, for instance, talking about HIV or talking about a person that lives with HIV, the manner in which they discuss the issue is the one discouraging the people from getting tested.
What is that manner? Let's get into the nitty-gritty.
All right. Can I give practical scenarios? Let's say there's a statement that is so common now among young people. They say if you go for tests like every now and then, you find what you're looking for. You know, that's a statement that discourages people. Another term are things, basic things like, you know, they regard you as a dead person. Do you understand?
So you almost look like you lose your right to life almost.
Exactly.
Okay.
Look, I'm very strong. I accepted my status, but things that I go through every day, the humiliation, the insult, everywhere, especially on social media, whatever I say, people refer me to HIV. Whatever I do, people take me back. You know, those are the things. Now, there are people that are looking toward that, and they were maybe in the process of getting tested. What will they think? What will they do?
Sandy, I think we should bring you up at this point because, I mean, you're obviously in charge of a network that provides services. And when you hear these challenges, and the theme this year is Know Your Status, what's your response to many other people that might be experiencing this type of challenge?
Thank you. I think the discussion that the Minister has shared with us, the stigma is the biggest barrier that we will continue to face. And if you're hearing from Shefeni what he's just heard now, it definitely prohibits people from accessing services. People are listening to what we are discussing in all kinds of circles, and that creates fear. We have our own prejudice about HIV. We have got our own perceptions, and sometimes that are very wrong. But we're dealing with these cases on a daily basis where people actually cannot go to access services because they say, we have gone through this. Sometimes even experiencing these problems even in health facilities, not necessarily outside the facilities themselves. When they get there, when you're dealing with people that are like key population, when they go there, they are with an STI, for instance, they are just shunned off. They are not able to access the services because the health provider is not maybe well trained to actually handle those cases. So that's the kind of situation that we're dealing with. Young people, for instance, have got their own challenges. They experience rejection, they experience challenges in health facilities and so on. So I think those are the kind of things that when we are talking about know your status, we need to remove those barriers for people to actually know their status. It's not just going to say, wake up now, know your status. Know your status, get to the facility, get tested to know, because you need to go for a service to get to know your status.
But given that, Mr. Tjiroze, one has to then say that it's not just an ad hoc problem, that some of them it could be systemic, some of them could be resource-oriented, some of them could be in terms of, where do I go in rural community access? So somebody like PEPFAR, who is a big partner to government, how do you ensure that the response is not, is systemic, that it's well-resourced, and that it's able to provide the necessary services to the people?
Yeah, I think that's a very important question, and I think at the offset we should commend the Namibian government because they carry the burden of sort of responding to this epidemic. I think they cover more than 65% of the response, with donors and private sector and civil society to some extent chipping in for the rest. So there's strong political leadership, and the government actually invests the majority. And it's commendable because this is an exception, because a lot of countries, especially in sub-Saharan Africa, don't even cover half. They cover less than half the response. So I think that's commendable. So then I think usually the government strategy, and I think Mr. Sharonda will also be able to testify to this, is to address mostly sort of the general epidemic profile of the general epidemic, whereas then development partners come into developing more resilient health systems and also using data to target special populations that are a bit more stubborn to get to or to treat. These are, again, populations like adolescent girls and young women, female sex workers, and other special populations that you can't reach through a general program, but you need more targeted programs towards. So some of the system building ones is to ensure that, for example, the supply chain that brings us the rapid test kits and the ARVs is efficient to be able to deliver those, that it minimizes stockouts. And, for example, to also the data collection system, the data systems, that they are robust. We're able to collect information and use that information to target areas where there are new incidences or where the prevalence is higher, or where treatment, people are not adhering on treatment and so on. So I think that's where donors come in, using their technical expertise from other countries and that they might have learned from here to provide targeted intervention, to support the government with targeted interventions.
Okay. Given that, maybe we can just talk about the role or the weight of testing in the overall fight, because we know there's an issue around prevention, there's an issue around treatment. How does the testing aspect directly address the fight against HIV?
Well, to put it shortly, I think in terms of the testing is the first door. We are all aware of the UNAIDS 1999 fast-track targets. Basically, it says that we should try and test 90% in terms of people who are HIV positive. We should also, in terms of try to get the 90% that have been tested positive, get them on treatment, and also ensure that there's a viral load suppression of those 90%. Currently, we're doing good in terms of the other 290s, getting them on treatment and making sure that there's viral suppression, talking about 91 and 96 respectively. With the testing, I think we currently at 86%, if I'm not mistaken. And these are some of those targeted areas or populations that need to be found. And these are also people that might not necessarily know their HIV status, that might not know they might be HIV positive. And this is basically the reason why some of these interventions have basically been strengthened, in making sure that we go out there within the community. So again, testing in itself, it's very important, because then it provides for people to at least start living positively with regard to their lifestyles in terms of behaviors. It also plays a role in terms of, people protecting these specific status, being negative or positive, and then also making sure that they protect their partners. So holistically, when you look at HIV prevention or treatment thereof, you need to know the status. This door needs to be open first, and we need to make sure that we basically take full advantage of this testing and make sure that there's quite a big number of people that we basically take on board to reach their first 90.
But do you think the reason why we can't bridge that other 4%, for instance, is in the insert we heard about multi-disease testing? Should this become a primary intervention versus, isolating HIV testing away from the possible other illnesses? Is this very much an anti-HIV approach versus a pro-health approach, part of the challenge of why us not reaching this particular target of testing? Shufini? My question is, would people living with HIV or people in the society prefer multi-disease testing that incorporates HIV amongst possible other diseases that you might have versus this isolated approach of just testing for HIV, which could then reap on the stigma that we spoke about earlier? What's a better model? That's my question.
The current model is working. The problem, we still come back to our behaviors as people. The whole programs, the whole rollout, everything is perfect. The resources are in place, the staff are all in place. All we need to do is, I think, it have to do with behavior changes.
My question is, are people more likely to go get tested if it's under the auspices of multi-disease testing versus just getting tested for HIV? I don't know, anybody on the panel?
Can I just chip it quickly? Yeah. Interesting enough is that the model that we're delivering these services is such a way that it's more comprehensive. Right now, we're also targeting men. And men are not only targeted for testing for HIV, they're also being targeted for testing the lifestyle diseases in terms of your high blood pressures, also in terms of diabetes, and all that. So it's more holistic in terms of how we're trying to attract men to get on board with regard to HIV testing. So
yeah, I think that is true. And I think, again, as we get closer to epidemic control, and we're trying to go that last mile to get these people that are a bit stubborn to get to, or they're difficult to get to, there are certain people that are, we heard about youth and especially young men not exhibiting health-seeking behavior. So if you wait for them to come into sort of the clinics or the facility and then get this sort of multi-disease screening, it's unlikely. It's only those people who are either sick or who are trying to, who normally come in, who you'll get. But those difficult ones that are unlikely to get tested or to come in for testing, you won't get them. So that's why you have, like you had, the index partner testing where...
Yeah, I was going to ask that next question.
Yeah.
Maybe just first explain to us, and you're talking about data earlier on, associated to what type of new data has this method introduced? What have you gotten insight into that we didn't have before?
Well, I think the first thing is that as you were screening, you try to capture as much information about the person's circumstances and profile. So their children, their sexual partners, if they're there, and you're then able to take that information. Instead of waiting for those people to come into the facility, you go out into the community, into their houses, and do the counseling and testing, and you're able to get that information. So that's sort of one of the data points that you gather. And as we, again, try to look at methods that yield more positives, that are able to get us this last sort of bastions of people that are positive but don't know their status, that's what we need to go to. The other data point that we use is this viral load testing. Where we're able to see, whether you're adhering to treatment, whether your viral load is reduced and so on. And then we're able to either see that either you're not adhering, you're not taking your medication consistently, or maybe it's not working, we need to sort of change to a different regimen. So that's the use of data through testing and through collecting data and using that to get people to know their status.
Okay. Sandy, I think what's important from your kind of perspective is the provision of services. We're not just talking about the testing. I mean, how has testing evolved? We heard the U.S. ambassador there talk about self-testing kits. Just talk to us about the evolution of testing and what are some of the pros and cons of the current methodologies?
Yeah, I think as he said, I will take it from what Mawa just said. The use of data will tell you will communicate to you different messages. One of the things that the data is right now communicating to us is that there are groups called the drivers of the epidemic. And this is the last group, as he rightly, in his own ways, that are called the stubborn group, but they're hard to reach populations. And those are the groups that you need to target with packaged services that are targeted at them. But I also acknowledge that in some way we are starting to talk about also and look at critically how do we make sure that we have integrated service delivery models where we make sure that like countries like Zambia, for instance, they have made sure that they made testing mandatory. That's when you get into their facilities, one of the things that you should be expecting is you have to go for testing to be part of the package. So, but we can do a dual prong, but there is also, we need to create an opportunity to make sure that we reach those that are outside there. So we have created various services like mobile services for young people, adolescents, which reaches to where they are, and organizations like NAPA and Walvis Bay Corridor Group are in that space. We have got services, for instance, that are targeting sex workers, organizations like SFH are on that space, and making sure that you reach them. Sometimes we even have to reach them at odd hours, like we used to have what we call moonlight testing services. That means services that are targeting the hours that the clients are actually mobile moving, because sex workers are not moving during the day. They are busy during the evening, and that's the time that you are actually getting them to the services. Interestingly, even the general population used to use that service. So it tells us also another story. But I think, as we said, we have evolved over time. We have now even gotten to the space where we are talking about, is it called voluntary test kits, where somebody can actually walk into the pharmacy and get
self-testing.
Self-testing, and that itself is actually now picking up. So there are so many things that we need to continue to change, because we're working with a disease that keeps on changing, but we need to keep on moving with the pace that it's moving.
Okay. This idea that he brought up, what to do in Zambia, voluntary versus mandatory, is that the missing link to get us beyond those 90s figures?
Well, I think right now, currently, it's really difficult. There's a discussion that hasn't started to happen in terms of the country. Maybe can be explored down the...
Well, what's the Minister's position on it?
Right now, it's just that the encouragement of people to know their status. We're trying to put efforts in place in making sure that we penetrate the communities and try to get some of this missing population. This is also in terms of targeting delivery. So we're looking at adolescent girls, young women. We're looking at men who have...
But wouldn't we raise the stakes? Wouldn't we raise the stakes by making it mandatory? If you are using public services for whatever reason, then won't we get the data that's necessary? I mean, it seems like Zambia could be on something. I'm not saying that it's not contextual here, but how is the government dealing with that concept of mandatory testing?
Yeah, we get you, but right now what we're saying is that that's a discussion that probably needs to happen.
So it hasn't happened yet?
Not yet.
Why not?
And that's probably in terms of one of the interventions that need to be explored.
Well, I mean, I don't know, even to start off, the constitutionality or the legality thereof. I guess that's something that we need to explore. That can we even do that within sort of the context of, I mean, we're not Zambia, of our constitution and what we can do. That's the first thing. Then the other thing is we need to sort of be cautious about things that might actually hamper the cause. For example, if you make it mandatory, already we're struggling with the group that we're struggling to get, the youth and the young people, are already not exhibiting health-seeking behavior. So if you make it mandatory, is that likely going to, is it likely to make them want to come into the centers or to places, even with other diseases, if they know they're going to get tested and they're uncomfortable or not ready for it? So I think that might be problematic and might actually set us back, just from a programmatic point of view, other than legal. I mean, the legal point is something else as well.
Okay. But earlier, Shifini, again, because there seems to be a relationship here in terms of the awareness of what we have in terms of HIV being a medical condition versus the kind of idea that it's like a death sentence, a death threat. How do we make this a medical issue? I mean, because if I understand it from a medical point of view, I would want to get tested because it's almost like a pro-health approach. So how is it that HIV is presented that people don't understand it as a medical condition and therefore you would seek medical help? Mr. Shifini.
I think earlier you mentioned a country like Zambia. I think Zambia did their best when it comes to stigma. I was in Zambia last week, and I attended an event on World AIDS Day commemoration, and you can tell the progress in which they did in terms of fighting the stigma. If we can follow suit, if we can also do like Zambia did, we can as well also catch up and then maybe do a mandatory testing for HIV as well.
Okay, so we have different opinions on this one.
Just quickly in terms of contribution, when you do a comparison, when you look at quite other countries in Africa in terms of the SADC, we far beyond in terms of ahead with regard to attaining the 1990 prong. Again, when you look at HIV itself, this is not a death sentence anymore. Back then, you were talking about people who were afraid of dying once they tested HIV positive. And then you also had that lack of treatment. And also in terms of the discrimination that really hampered in terms of people accessing these services. Right now, it has become one of those lifestyle diseases. I mean, you can go on your medication and still live longer than a person who's HIV negative. So I think people have started coming around in terms of the idea that, you know, they can be all right once they start taking their medication. And the sooner they do that, the better. So I think that's basically in terms of where we're looking at.
Okay. Stanley, let's talk a little bit about facilities and infrastructure that supports testing, especially the difference between urban kind of settings and rural settings. How has that evolved over time?
Yeah, we have moved from the voluntary counseling, the VCTs that you wish to know of, which were also very much isolated spots. And I think one thing that also one has to understand is infrastructure can also create a barrier. So we have moved away from that right now. And I think even within our facilities, the mobile facilities that we have, as my brother from Sharonda was talking, is that we're trying to look at various conditions that the person has. Obviously, we'll encourage the person to actually also go for. When I was in World AIDS Day in Hong Kong, I did my testing, and I went for all the tests, a whole comprehensive package that I went through. I went through my prostate test. I did my weight, I did my height, I did everything, BMI, BP. So ultimately, I could make informed decisions in terms of how do I even just look after my weight, for instance, because weight could be something that I need to look at. So I think, the facilities, currently we are working very closely, whether the community service facilities with the government facilities. We're working very closely together, and the synergies are really helping us a lot. And that is why currently we are seeing the kind of percentage that Namibia is recording right now, particularly because of the synergies and the collaboration that is there between government and community interventions. We used to have what we call door-to-door testing services under DAPP, which was very, very important, where our colleagues will go into homes and do, in a family setup, and do conducted testing, and then do referrals immediately to the facility. So this symbiotic synergy is very, very important.
Okay. What's interesting, Mr. Mama, maybe you can talk to this issue about Namibia's reclassification into an upper middle income country and how that's affected resource mobilization to maybe bridge the existing, whether it's prevalence that's occurring or to sustain the efforts that have been made to fight HIV/AIDS. You also saw, and then also that a lot of NGOs in civil society don't exist anymore. How has that affected the very issue of testing or treatment?
I think it's a tough one. Again, I'll go back to say that the government has done a great job because they carry the burden of most of the response. So when there are shocks like withdrawals or decrease in external funding, it doesn't put the response at risk that much. I can only talk for PEPFAR that we look at it more from an epidemic control point of view, whether you are middle income or whatever. We look at the profile of the epidemic and what we need to do to reach epidemic control. So in fact, we've had I think 2 or 3 years ago, we had an acceleration plan that actually increased the resources that we put into Namibia. And that sort of, since then, hasn't really gone down. It's been more or less consistent.
Well, my question really has to do with the role of civil society and its significance in especially things like destigmatizing, because civil society is more of a grassroots intervention, but a lot of PEPFAR money might be going into, state-down, top-down approaches. So, Sandy, in your experience, what has the loss of those civil society organizations done for things like stigma, for things like encouraging testing, pro-health approaches? What have you lost?
Yeah, I think one I will take the departure of saying that when we are doing what we call demand creation or community mobilization, which is what we do as community interventions level, we try to encourage and create behavioral change through information, but we try to encourage our clients to go to the facilities. That is improving their